So in this last section, we're going to talk about some general anesthesia techniques that you guys have been using. So, what is general anesthesia? As we talked about it earlier, it's a state of unconsciousness where pharmacologic agents produce hypnosis, amnesia, and analgesia. And other endpoints met during most general anesthetics include muscle relaxation that causes immobility and attenuation of the sympathetic and somatic reflexes. You can induce the patients by either IV or inhalation. You can maintain the patients, and this maintenance phase begins when the amnestic patient is not only unconscious but also unable to produce movements in response to surgery. And at this point, there are several techniques available for you to maintain general anesthesia during a given procedure. So, total inhalation anesthesia. This technique involves the sole administration of total inhalation anesthesia. So, with total inhalation anesthesia, you only use an inhalation agents like SIBO to maintain general anesthesia. And an example of this would be when you're doing a PE tube and you don't use any drugs except inhalation anesthetic. Advantages of this approach include the ability to maintain spontaneous ventilation and satisfactory blunting of the sympathetic responses to nausea stimulation. Modern agents are easier to titrate to the patient's blood pressure, pulse, minute ventilation, and movements. So this is comparing sevoflurane with halothane or older agents, ether, that we don't even have access to. The major disadvantage of this technique is the significant dose-dependent cardiovascular depression. And in case of SIBO, it's primarily vasodilation, not as much cardiac depression. Back in the old days with halothane, it was primarily cardiac inhibition. In addition, these volatile agents don't provide great level of analgesia. This approach is most useful for short procedures where intra-op and post-op pain is expected to be minimal, like ear tube, cysto, or procedures for exam under anesthesia. For TIVA, you can use continuous infusions or repeated doses of short-acting hypnotics. You know which one I recommend, my personal preferences, but we usually add opioids for those procedures that may produce more than minimal stimulation. There are several advantages of TIVA over other modes of maintaining anesthesia. One is decreasing incidence of post-op nausea and vomiting. Of course, it depends on what you use. If you use propofol, yes. If you use etomidate infusion, probably not. They result in rapid induction and easy titration of the medication. Also, rapid emergence even after long infusions due to favorable context-sensitive half-times of propofol. Usually, there's no risk of malignant hyperthermia unless you add SUX to it. There's minimal suppression of neurophysiologic evoked potential, so very useful for neurosurgery. Also, there's avoidance of exposure, the occupational exposure, or environmental pollution by volatile agents. No need for gas delivery or scavenging systems, so very good for office procedures. No expansion of gas cavities, unlike nitrous oxide. And they may reduce intracranial pressure, specifically propofol. TIVA is used quite extensively for deep sedation and maintenance of in ambulatory surgery. It's a simple technique that leads to rapid and clear emergence with minimal post-op nausea and vomiting. TIVA is especially useful for maintaining general anesthesia when delivery of gases may be difficult, like people with pulmonary disease that impair ventilation and perfusion to the lung can lead to inconsistent drug uptake. TIVA allows for a much more rapid onset of action that doesn't depend on the adequacy of alveolar ventilation. TIVA is also suitable for procedures where ventilation is interrupted, like laser airway surgery or bronchs. There are several disadvantages to TIVA too when you use it for maintenance or deep sedation. There's a need for multiple infusion pumps compared to just one vaporizer. More expensive. Is the cost worth the benefit? And again, this is a controversial issue because the cost that we pay for it compared to overall costs, like how long the patient is in the PACU, that can be debated. There's variability in patient dose requirement and pharmacokinetics. There's an ability to measure blood concentration of IV anesthetics for now. There is greater incidence of patient movement with TIVA, and many different drugs can be chosen to provide TIVA. The most popular combination is a sedative hypnotic plus an opioid. So propofol has become the most common agents used for infusions of sedative hypnotic. It results in good amnesia, hypnosis, and even antiemetic properties, all with a short duration of action. Adding an opioid infusion, usually Remi, allows for a short-acting analgesia. Titration of the drug dosages can take place against measurements of the BIS or SED line for propofol and hemodynamic changes for surgical stimulation to those opioids. The options for TIVA include infusion of Dex, ketamine, or any other opioids. General anesthesia using a single drug may require doses that produce excessive cardiovascular compromise. So that's where balanced anesthesia technique comes. And this is probably the most common approach to maintaining general anesthesia. The concept of balanced anesthesia is based on combining multiple classes of drugs to achieve the desired endpoints of general anesthesia. Targeting different receptors allows us to use lower dosages, so at least theoretically fewer side effects. A balanced technique will often produce less hypotension and cardiovascular depression than a pure inhalation or IV technique. This is not a new concept. As new drugs were made over the past century, they quickly became part of the administration of anesthesia. Like meperidine was often used as an adjunct to nitrous oxide, starting back in the 40s. Now we have better drugs. And a typical balanced technique right now can include a potent inhalation agent like SIVO to produce amnesia, unconsciousness, immobility, autonomic attenuation, a benzo like midazolam to produce amnesia, an opioid like fentanyl for analgesia, a muscle relaxant like rock for immobility, an IV sedative hypnotic like propofol to induce unconsciousness. Opioids are one of the key components of this balance technique. Their primary role is to reduce pain. They also reduce the requirements for both IV and inhalational agents, attenuate autonomic responses to airway and surgical manipulation, and help maintain hemodynamic stability. However, these drugs should not be given before the onset of nauseous stimulation. They should be given way before that. For example, when you use fentanyl, you have to give it at least 5 minutes before surgical incision for it to be effective. If you give it a minute before or as they're cutting, it's too late. Sufficient time is necessary for them to be truly effective. And the most forgiving one is remifentanil because it has an onset of 1 to 2 minutes. And if you use longer acting drugs, more water soluble like morphine, meperidine, or hydromorphone, you have to think about it way ahead of time. What is nitrous opioid technique? Now, because of their low solubility, volatile agents like DES and SIVO are key agents used nowadays for inhalational agents. Back in the old days, when more soluble drugs like enflurane and halothane were options, nitrous was the most commonly used inhalation technique. And as you know, nitrous has low potency, so 1 MAC is 104%, but very extremely favorable pharmacokinetics because it's low solubility. One technique for general anesthesia that we don't use as much anymore is using high-dose nitrous, 70%, combined with opioids and muscle relaxant. And we use opioids and dose it based on the response to changes in pulse and blood pressure. And again, with this technique, the opioids have to be dosed regularly, and have to use muscle relaxants to prevent patient movements in this technique. And of course, you need mechanical ventilation. With this technique, emergence from general anesthesia is quite nice and smooth because of the opioids, and also rapid because of how quickly nitrous oxide dissipates. In addition, patients tend to have less anesthetic-induced vasodilation and hypotension during the case. But the potential for intraoperative is a significant concern with this technique, especially in sicker patients where we use light anesthesia. So, benzodiazepine has to be added to this technique. What about combined general regional? Now, general anesthesia, you can combine it with regional anesthesia to maximize the advantages of both techniques while minimizing the potential complications. The most common approach involves administration of an epidural or a peripheral nerve block and then induce the patient or do deep sedation. As you can imagine, epidural catheters should be placed at the appropriate level for the surgery. And for epidural catheter, this technique assumed the local anesthetic would be administered during the procedure, not just at the end. Advantages of this technique include avoidance of opioids or using much less opioids, less post-op nausea vomiting, higher quality of post-op analgesia, preemptive analgesia, maintenance of secure airway with a endotracheal tube or laryngeal mask airway, less patient movement, improved suppression of endocrine stress response during surgery, faster return of valve function, lower incidence of post-op pulmonary complication. And this approach may yield several problems though. For example, greater degree of hypotension due to sympathectomy from particularly neoaxial techniques, risk of nerve injury, epidural hematoma, high risk of local anesthetic systemic toxicity, and time-consuming placement, which in many places that can be a problem.